Hi, and now we're into part 3, looking at treatment for mood disorders and also looking at the issue of suicide. Now, as we have seen with the theorists, there is different perspectives. And just as with that, there will be many possible explanations, not only in terms of theory, but also in terms of treatment. So it's the case with treatment approaches. There's psychological to biological. And we're going to consider some of the more leading contemporary approaches to treatment. Now, please remember to use your textbook as an augmentative piece to what I'm doing in the videos here. That the bulk of the information is in your textbook. I'm trying to highlight some of the key points that you should be focusing on. So don't disregard your textbook. It's important, and make notes. Alrighty, carry on, and we're finishing up week 5 with this part 3 video, and next week we'll be looking at week 6 material. Alright, bye now. Now, looking at treatment of mood disorders, we'll start with the psychodynamic approaches. Psychodynamic treatment of depression has traditionally focused on helping the depressed person uncover and work through ambivalent feelings towards lost objects, thereby lessening the anger directed inward. Now remember, lost objects hasn't got to do with things necessarily, although it can. Oftentimes it's people or loved ones. Now, more modern psychodynamic approaches tend to be more direct and briefer. That is, instead of taking years, it takes months. And the focus is on developing more adaptive means of achieving self-worth and resolving interpersonal conflicts. The focus is on the here and now rather than the unconscious and childhood experiences. Now, the more focus on the behavioral approaches, they consider that depression is learned and can be unlearned, and they'll use an approach called coping with depression. It's a course. Learning theory approaches have focused on helping people with depression increase the frequency of reinforcement in their lives through such means as increasing the rate of pleasant activities in which they can participate in, and assessing to develop relaxation strategies, how to develop a self-change plan for more effective social skills to increase their ability to obtain social reinforcements from others. Now, the cognitive approach, if we were looking at it more generally, again, check out table 4.6 on page 170. The cognitive therapists are focusing on helping depressed people identify and correct distorted and dysfunctional thoughts that are learned and learn more adaptive behavior. And that's really an important element. Now, if you can want to remember about distorted thoughts, there they are on page 158-59. Now, the focus is on learning new ones, learning one's own dysfunctional thinking, and developing more adaptive behaviors. Will often use a thought diary to help clients to increase the self-awareness and to better manage their adaptive choices. And when you gather this sort of data over time, one, you become more self-aware of what affects you, when it affects you, under what circumstances it affects you. And from that can learn what strategies you could use in place of the existing strategies that you've been using. Now, a biological approach have focused on the use of antidepressants and drugs, antidepressant drugs and other biological treatments such as electroconvulsive therapy, or ECT. Antidepressant drugs appear to increase the levels of neurotransmitters in the brain. You could start out with TCA, or tricyclic antidepressant, MAO, which would be the monoamine oxidase inhibitor, or the SSRI, selective serotonin uptake inhibitors. Now, as far as bipolar disorder is more commonly treated with lithium, it's effective in stabilizing moods and reducing depressed and mania episodes. Now, a more like an older style approach that has a new spin on it, which would be the ECT, despite significant controversy, ECT is a treatment of choice for very severe depression. The person is anesthetized and is given a muscle relaxing drug. They are then given a brief, less than 1 second shock directly to the brain. The result is a brief seizure lasting several minutes, Treatment usually administered once every other day for 6 to 10 treatments. The side effects include short-term memory loss and confusion, which usually disappear within 2 weeks. It's quite successful. 50 to 70% of the people who do not respond to medication do seem to respond well to ECT. Now, as was mentioned, a separate topic that's related to depression, because a lot of the connection between people who are depressed and the onset of potential suicide attempts is fairly significant. So we'll look at suicide, and generally who commits suicide. Well, one of the leading causes of death in both men and women from adolescence to middle age is suicide. Mood disorders are often linked to suicide, although women are more likely to attempt suicide than men, and more men actually succeed, and it's probably because they select more lethal means. The elderly, not the young, are most likely to commit suicide, and the rate of suicide among the elderly appears to be increasing. Now you see there's 28% of people between the ages of 85 and 89 years old. 24% of those who commit suicide are in that area of 15 to 24, and 16% of people who commit suicide are 25 to 44. Now, when we think in terms of, well, why do people commit suicide? Well, there's probably not, again, a single cause. There's many theories. People who commit suicide are often depressed, but are generally in touch with reality. The classic psychodynamic approach from Freud is a representation of inward-directed anger, and turning that anger towards themselves rather than towards what they want or what they need or who they're angry at. Sociologist Emil Durkheim identified the concept of what's known as anomie. Anomie is the feelings of alienation and disconnectedness you have from other people. Now, we are more likely to commit suicide when we feel alienated and disconnected. This fits the sociocultural view of today. The distance we travel to school, to work, the bigger cities that we are a part in, the less connectedness that we have increases the likelihood that if someone is depressed, along with these other environmental conditions, could increase the likelihood that they may attempt or commit suicide. Now, the learning approach looked to the possible reinforcing effects of threats or attempts and the effects on stress. They may, however, lack the effective problem-solving skills and see no other way to deal with some of their life stressors other than suicide. From a sociocultural perspective, the part of the belief that suicide is somehow an acceptable way to solve problems once and for all, rather than working at them a bit at a time. There are some social reinforcements for the examples of others who have committed suicide. It's called a social contagion. And seeing, where they see the suicide of others as courageous and somehow heroic. And then lastly, there's biological. The neurotransmitter serotonin may be maybe deficit, may not have as much, and it appears to be a common in those who are depressed and or those who attempt suicide. Now, of course, there are things that we can do when we know people, or if we're working in the field of people who are depressed. And one of the ways, some of the things that we can do would be to draw the person out, where essentially you're sort of asking questions, tapping into them, just talking about what's on their mind to find, for them to recognize that someone is paying attention to them. Be sympathetic. Now, sympathetic and empathy are two different things, and it's important to be able to empathize without trying to express how much you think you understand, because, of course, anybody who's going through something doesn't really feel that anybody understands. You're saying you understand doesn't convince them that you do. Suggest that means other than suicide can be discovered to work out their problems, and being positive and looking at other alternatives that either you can help them with or that you can direct them to get that help. Inquire as to how the person expects to commit suicide, like what's being, what the expectation is here is to sort of round out the entire experience that they're having, and how have they thought about this, and what other alternatives have they considered, and can we explore other situations? It's also really important not to degrade the individual and somehow saying, you know, you're talking crazy. That's to sort of say you don't know what you're talking about, and that just really emphasizes how little you may in fact understand their circumstance. But lastly, and certainly not leastly, is propose that the person accompany you to see a professional right now. Well, I hope this has been a useful and helpful chapter. We've got, what, 2 more weeks, I guess, until the break. So good luck with this for everybody, and keep up the good work. Bye now.